Hi there. So this video is for people who are joining the short version of the Enhanced Functional Assessment in Urgent Emergency and Acute Care course, the half-day version. The idea of the video is to introduce you to the course and cover some of the essential information so as to allow for as much time as possible to practice the skills during the course. If you're attending the full day course, then you don't need to stay to watch the video. The contents of this video will be covered again on the 4-day course, but you may be interested to stay and watch for your benefit and familiarization to some of the learning topics. If you're not booked onto any of these courses, but you are interested to know more, then you can visit my website www.tetracks.co.uk and find out about this and other courses that we offer. Again, you're welcome to stay and watch this video and find out more about the kind of content that we cover in our courses. So my name is Thomas Edwards. I'm an occupational therapist, adult educator and advanced clinical practitioner. I created this course because I undertook my own Masters in Advanced Practice, and whilst learning some of the clinical examination skills, many of those were just as relevant to my practice as an occupational therapist in urgent, emergency and acute care. And so I wanted to create learning to educate and share that with other allied health professionals and other healthcare professionals as a wider group, because many of these skills can be used within the functional assessment or adjacent to the functional assessment to ensure that we're meeting the person's needs, that we're getting a detailed assessment, and gives us confidence in our clinical reasoning. It allows us to make earlier and more effective decisions for the patients and with the patients. So I created this 1-day course to cover some of the essential skills that I believe can be related and added to the functional assessment. And I believe that the functional assessment often provides an additional kind of layer to, I guess, the medical examination in terms of particularly presentations where there's no obvious acute medical cause, or certainly that cause is less of a concern, and yet the patient is struggling to carry out the daily activities or to mobilize. And this is where I believe that as allied health professionals, we have the opportunity to provide our expertise with this group of patients, to provide a detailed assessment, make a decision or an opinion of what we believe is causing that change in that person's function, and be able to share that with the multidisciplinary team, because that can often support better decision making, earlier diagnosis, and earlier outcomes, either sometimes if the patient needs transferring to hospital or admitting, but in many cases it can help us to discharge patients earlier too, so it supports flow. Throughout this course and all the courses that we run, I believe that learning styles are really important, and I create the learning activities to meet as many of the learning styles as possible. And part of your introduction to this course, I'd really encourage you to go and visit the Learn-Vark website and find out your own personal learning style, and use this to learn in the best way for you, the way that works best for you to get the most out of this course. You may also be interested in the Honey and Mumford learning styles. These are more theoretical based, but they are quite useful, particularly if you find learning difficult, to better understand how you prefer to learn and what resources to access to help you to do that. Another method of learning is by considering your knowledge and how much you know about each of the body systems that we cover. And the important part of that is to continuously challenge your knowledge and grow your knowledge. So once you understand, for example, the system or the organ and how that works and why it works, move on to the tissue and the cellular level, molecular level, and then eventually the chemical level. Because the more and more you learn, the more you understand of what's going on in the body, and the more you can relate that back to your assessment, and that supports your clinical reasoning. So I just find this quite a good way of helping us to learn. So these are the aims and the objectives of the entire course. I won't talk through them now because this session is really only covering the first objective and parts of the remaining objectives. But if you want to read through them, you're welcome to pause the video. So I'm going to start by looking at the medical examination. For me, this is really important. Firstly, we need to understand what's already been done, but also to understand where we may need to fill in some of those gaps. And the first activity, we're going to look at what is kind of the gold standard, the expected framework of the medical examination. And I want you to look through it and think about how much of this is actually done, how much of this do you see in patients' notes every day. Because often things are missed out, and they're missed out not because anyone's done anything wrong or they've not assessed the patient thoroughly. It's simply because at that time that amount of assessment was indicated. But that doesn't mean to say the patient doesn't need more assessment, and often it's the functional assessment that raises some of those additional kind of medical concerns. And so if we understand what of the medical examination has been done, and also just as importantly what hasn't been done, then we can help to contribute towards that and provide them a holistic, sort of three-dimensional assessment of the patient, bring that back to the multidisciplinary team, and then make more effective decisions together so that we don't delay the care or the diagnosis that the patient may need. So I'm just going to move through the next 3 slides fairly quickly, so do pause them, pause the video on each slide and have a look through. If you're attending the short course, you'll also get a link to the handouts for the day, and this is included within that pack. Like I say, this is a sort of the gold standard. I've adapted it from Geeky Medics. They provide a great YouTube channel with lots of really useful videos, primarily aimed at doctors doing their OSCEs, but they're very educational, and this has come from their Falls assessment page. So like I say, these are the things that doctors are recommending to doctors to complete with a patient who has presented with a fall or other acute functional changes. But I'm sure, like me, your experience is not all of these things are done. And like I say, my experience is when I look at a medical examination, if it's very thorough, it gives me some assurance that everything has been done. But if there's gaps missing, I will tend to still add some additional assessments into my own assessment to either confirm what the medical examination says or to potentially then identify concerns or gaps where they hadn't been covered previously. Another important thing to consider is medical red flags. These are signs of potentially quite acute, serious acute illness that aren't normally indicative on an initial presentation. So sometimes patients may present with these conditions, but it may not be immediately obvious. They may not look particularly unwell. Their new score may be 0 or very low at least. And yet, through a more kind of functional based comprehensive assessment, we can identify these concerns. So I think it's really important that we're familiar with those red flags, both in terms of cautioning us to not proceed with an assessment, but also then to obviously raise those concerns, because often, like I say, we can contribute to that assessment. So what I want you to do is just to look at the the symptoms, which are the white boxes, and then link them to the underlying cause, the red boxes. Now, some of them may be related to a couple of different ones, but they are all connected to one box. But often these things do overlap, so don't worry too much if you can't decide which categories are connected. But just take a moment, pause the video, and start to make some of those connections. Again, this activity is in the handout pack that I provide to the short day course. Okay, if you're not ready yet, then pause the video, but otherwise we'll move on. And so here's the answers. So again, if you want to take a moment, just have a look and see what you got right and where you weren't so sure, pause the video and you can take a moment to do that. Okay, we're going to move on to the next slide now. Okay. So when I first started running this course, one of the feedback I got was that people found the content really useful, but wanted a bit more of a structure to how they go about assessing a patient. So I came up with this model, which is the word anagram, I think it is, for accumulate. And I picked accumulate for a particular reason, because for me, we are accumulating that additional information, that functional assessment that supports kind of the overall assessment of the person's presentation and understanding what's going on, why it's going on, and then how we can respond to that problem. The enhanced functional assessment course will cover most of these points in more detail. The two I won't cover in either of the courses in any great detail is affect and communication. I'll touch on them briefly shortly, but these are areas you may want to look into in a bit more detail in your own time. Another important consideration with our functional assessment and how we're then supporting the wider MDT is to consider the biopsychosocial and environmental model. Often as AHPs, we are ideally placed to look beyond just the biological concerns and consider other components such as the psychological state, the social environment and the physical environments, and how they may influence both the functional difficulties and then also any other symptoms or underlying illness. And so, like I say, this is a really useful model to consider, particularly again in those situations where there may not be a clear medical cause for the change in a person's functional ability. It gives us as AHPs an opportunity to explore through our more detailed assessment a way of understanding what other factors may be then contributing. And there's some particular key factors that I would just like to emphasize. So in my experience, if a person's function has changed and there's no other obvious physiological cause, then in my experience, more often than not, it's dehydration or constipation. Dehydration is particularly important because if the body hasn't got enough fluid, it can affect the blood pressure, it can affect the electrolyte balance, and how the cells move the necessary chemicals in and out of the cells, essentially to support homeostasis. And so dehydration can often be quite a common problem. But how it creates an acute functional change is that often someone will have maybe chronic dehydration and not be taking much fluid in over a longer period of time, but they often get to that point from coping to not coping. And so it can seem quite an acute, sudden change, but often in the background with the history and with the presentation, there'll be this kind of history of poor or less fluid intake or oral intake that may be contributing to that dehydration, which might be leading to an acute functional change. Another really important topic to consider is polypharmacy. So polypharmacy in terms of four or more medications, either because those medications might be interacting together and kind of creating side effects, or just not causing those medications to maybe not work quite in the way they're designed to. Or often the person may have had an increase or a change in their medications, which changes again that kind of homeostatic balance, the physiological response to the body. And so it's often useful to explore medications, and particularly whether there's been any recent changes. But another thing to consider, if there's frailty or chronic dehydration, that the person's metabolism may have changed, and so the medication may now be stronger than it should be, or it may not be as effective as it should be as well. So do consider, particularly if someone's on a number of medications, that whether the medications could be contributing to this change, and consider looking to get a medication review. And then do also consider delirium. So often delirium can present in an acute medical situation, but it can also present in a more physical way. So you can have a situation where the person may present with delirium that's secondary to a more physical condition, such as an infection. Or you may have the situation that they aren't unwell, but simply the change of the environment has led to the delirium. So the example I often give is that the person who may come into A&E just because of a head injury following a fall, and they were not confused when they arrived in A&E, but the change of the environment might have led to some confusion. And so it's really important, and this is why the biopsychosocial and environmental model can be really useful in helping us just to consider what may be causing these factors, and gives us the opportunity to use our expertise and provide our specialist skills to support that more holistic assessment for the patient, that then helps with early decision making and early actions for the patient and for the service. So I briefly mentioned medications, and there's actually quite a lot of different medication groups that can affect things like falls, functional decline, dizziness, and delirium. These are just the kind of main categories, but within the link for all the resources that you get to the course after the course, you will find a full handout on these, which is worth looking into for your future development. So, like I say, the two areas I'm not really going to focus on too much is affect and communication. I think these are still really important topics to consider. The effect in terms of how the patient presents can sometimes give you some really subtle clues, either in terms of any underlying kind of illness or potentially neurological impairment, or it may also indicate the patient's mood or level of kind of motivations that might explain some of the causes of the presentation. Like I said, I'm not going to go into these in any great detail, but it's worth looking through in your own time to really familiarize yourself with different terms and consider how this may affect your assessment. And then similarly with communication, often in my experience, communication and subtle changes in communication can often indicate early onsets of kind of acute illness or kind of progression of diseases. And so although we don't often consider it necessarily sort of a change in function, and often where there is that severe change, we are more concerned anyway in terms of thinking like strokes and that kind of thing. But for mild changes, we don't necessarily take them into consideration so much. And yet, like I say, and like I'll talk through in the course, sometimes depending on the impairment, that change in communication could be a subtle clue of what's happening or what has happened. So it is useful to consider, and it is obviously still a functional concern in terms of the ability to carry out daily activities that require that level of kind of communication. So there's a couple more videos that I would recommend you look at that will be helpful for the course. This video is one of the videos by Geeky Medics. It's the upper limb neurological examination. Like I say, it's an OSCE guide for doctors, so it's a bit more thorough than us as allied health professionals would normally undertake. But I think it does provide a good level of assessment, and actually I cover most of this in the course anyway. So it's useful to watch just to understand kind of broadly what's expected and the kind of the level of detail that we will be working towards within the course. And then this gait examination video by Stanford Medicine is also quite a useful YouTube video to watch, which talks about the different types of gaits and the causes for those gaits. Again, walking gait can be quite a subtle but important indicator of either acute illness or just any kind of neurological or physical changes that can help us to determine what's actually going on. And so the video itself is a really clear explanation of the different kinds of gaits and what's causing that. In the course, we will look at the gait pattern and particularly in relation to kind of things like balance in a bit more detail. But like I say, that watching the video in advance can be quite helpful just so you're a bit more familiar with the different types of gaits and the underlying causes of those. So that's the end of the introductory presentation. I look forward to meeting everyone who are attending the courses. If you're not attending the course, then please do look into the courses that are on our website, www.tetracks.co.uk. And really just to emphasize that the course itself is only part of the learning. A lot of our ability to put this into practice and to carry it out on a regular basis is also about continuing developing our knowledge and skills, developing kind of case studies and reflections, particularly where we've been able to use those skills or where we could have used them and how they went. And then using those to take to supervision, have that ongoing development discussion about our role and our skills. Within the course itself, you'll get the opportunity to look at other topics around kind of cognition and the neurological system, and then look at different approaches to assessing these in the context of function. So thank you for taking your time to watch this video. If you have any comments on the video itself, then please do get in touch. And otherwise, I look forward to meeting you on a future course.